Epinephrine is the cornerstone of cardiac arrest resuscitation. Other than maybe rapid intubation, giving epinephrine is the single most important thing you can do to improve patient-oriented outcomes. Give it early, give it often, give it all. Yes, that is my hostage script. If you hear me saying that, please call for help. Now, what I meant to say there is that while historically epinephrine has been used up until recently with very little evidence, we don't actually know what its role in cardiac arrest resuscitation is. Now, our story so far. Multiple observational trials have shown a clear association between epinephrine and more ROSC, but not much difference, if any, in survival. Now, the PACA trial in Australia confirmed this. Then Paramedic 2 came along and offered the best evidence we have to date. So what do we know? Epinephrine saves the heart at the expense of the brain. Now, what do I mean by that? Well, here's what we learned from Paramedic 2. We see more ROSC and a small but statistically significant 30-day survival. And by small, I mean 0.3% improved survival with epinephrine as opposed to placebo. Now, in that trial, there was no neurologically intact survival difference. So where is the expense of the brain part? We saw the improved survival part, but where is the expense of the brain? Well, it comes if you look at those who survived. Now, among those who survived in Paramedic 2, almost twice as many survivors had neurologic devastation with epinephrine. That turned out to be 31% with epinephrine versus 18% with placebo. Now, neurologically intact survival is the most patient-oriented outcome we can get. What do patients value? Well, it turns out the Paramedic 2 authors asked them. In a community survey prior to the study, 95% of respondents felt that long-term survival with good brain function was more important than living for just a few hours or a few extra days without that brain function. So it looks like epinephrine does a good job of starting the heart, but it appears to be hurting the brain. And maybe that's by leading to cerebral ischemia. Who knows what? It does. Now, is it possible that some epinephrine is good, but too much is bad? Maybe the 1 milligram every 3 to 5 minutes that we've historically given is actually too much epinephrine. Could less epinephrine be the sweet spot where we get the cardiac benefit without the brain damage? Well, stick around because we have a paper that looks at exactly that question.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. Now, this certainly is not the first episode in which I've spoken about epinephrine in cardiac arrest. In fact, our first episode ever was a rather lengthy, some may say rambling, podcast in which Mike Verkest and I did a deep dive into the literature and what it says on the subject, including a rather lengthy discussion of both PACA and Paramedic 2. We also looked at how airway management might impact the time to epinephrine in the PART trial, and we did that in episode 5. Now, the latest addition to the epinephrine literature that I want to talk about is the One and Done paper. This was out of North Carolina. It was published by Dr. Ashburn and colleagues and is titled One and Done Epinephrine in Out-of-Hospital Cardiac Arrest, ? Outcomes in a Multi-Agency United States study. It was published in Prehospital Emergency Care in September of 2022. Now, this was a before and after study of the impact of a new protocol in 5 third service EMS systems in North Carolina. These systems covered a total population of 850,000 people, and they included a variety of rural, suburban, and urban communities. They collected data using their EPCR data plus the CARES registry. Now, if you don't know about CARES, allow me to plug it. CARES is an amazing resource that is available to us here in the United States. It is the cardiac arrest registry to enhance survival. You can learn more about it at mycares.net. We participate in CARES at my system in Fort Worth and did so at both of my previous systems in Williamson County and in Marble Falls. In fact, one of our previous guests on this podcast, Dr. Ben Bobrow, who's the chair of the Department of Emergency Medicine at UT Houston, he has enabled all EMS agencies in Texas to participate for free. Thank you, Ben. We export our data in my system from our charts into the CARES dataset on the CARES website, and then that generates a notice to both our dispatch center and the hospital that we transported the patient to, assuming we transported. And both comms and the hospital then enter additional information about the arrest, including TCPR data and outcomes. It is perfect for research and, more importantly, perfect for quality improvement. Do your agency and your community a favor and check it out. If you're in Texas, there is no cost to it, no reason not to join. All right, so that is my PSA for CARES. Seriously, y'all, I really do love me some CARES. And the reason I bring it up here is that the authors used CARES to get the data for this study. Data collection, particularly getting hospital data, is typically one of the most challenging parts of any pre-hospital cardiac arrest study. And I'm guessing CARES made this study pretty straightforward for them. All right, with that in mind, let's run the PICO question. So the population studied was all consecutive adult non-traumatic cardiac arrest in these 5 communities that had resuscitation attempted anywhere between November of 2016 and the end of October 2019. The intervention was a protocol change that limited epinephrine in cardiac arrest to a single 1 milligram dose. After that, no more epi was given. And this is what they considered the after group. So the control group, that was the before group where they were still using standard ACLS dosing, 1 milligram epinephrine, 1 to 10,000 every 3 to 5 minutes. Their primary outcome was survival to hospital discharge regardless of neurologic function. Secondary outcomes were sustained ROSC and survival to hospital discharge with good neurologic function, as defined by a CPC of 1 or 2. Now, from an analysis standpoint, they performed a generalized estimating equation, or GEE, to determine the association between the protocol group, meaning the before or after group, and the outcome. Now, I know that y'all are sitting there going, Jeff, please tell us what a GEE is. That's what you're saying, right? Well, that's what I heard. So, as best I can tell, which means the best that I understand it from what Rimley tells me, is that a GEE is a type of logistic regression that can account for clustering effects. And clustering is where the outcome might be affected by the different clusters, in this case, different agencies. So think about it like this. In this study, some agencies may have better outcomes than others do because of something having nothing to do with this protocol. Maybe one agency does a better job of minimizing compression interruptions than another. Maybe one has TCPR and the others don't. Now, I have no idea if that's true in this case, but that's an example. And to control for it, they use a GEE, which does math, and that does it somehow. I don't know how. I plug it into R, I ask Rimley, it pops out. So, with that bit of nerdery out of the way, let's talk about what else they adjusted for. So we talked about the clustering effect. We know that some things like response time or age of a patient impact outcomes having nothing to do with protocols used. So they attempted to adjust for that, and they did it in the usual ways by looking at age and sex and race, the initial rhythm, meaning was it shockable or not, whether it was witnessed or not, whether there was bystander CPR, whether there was public access AED availability, and of course, EMS response time. They performed a separate sensitivity analysis, basically doing the same thing, but only looking at cases where the etiology was presumed to be cardiac. Remember, they were looking at non-traumatic arrest, and that includes lots of things other than cardiac etiology, things like, respiratory illnesses, for example. Now, they reported the association between the protocol group and the outcome in terms of odds ratios with 95% confidence intervals. Now, remember, my nerd friends, an odds ratio of 1 means there's no difference between the groups. So if you see a 95% confidence interval that includes 1, that means there is no statistically significant difference. Now for the results. The two groups were roughly similar. As usual, Table 1 describes the key characteristics of those two groups. Now, they didn't do any formal statistical testing of differences, but the only things that I could see that looked like they might be different all favored the post-implementation group, meaning if they really were different, we would expect the outcomes to be better in the post group. Now, those things included, I might add, the factors that were already adjusted for in their regression. So even if there were differences, I think they were things that were adequately controlled for. Now, overall, there were 899 patients in the before group and 791 in the after group. There was no significant difference in survival to hospital discharge, neurologically intact survival overall, or among survivors. And there was, however, less ROSC in the single-dose group. Remember the sensitivity analysis I talked about? The one that looked only at presumed cardiac etiology? Same results. No difference in survival, functional survival, but there was less ROSC. Now, I'm not going to get into the specific numbers here because I don't think they're really all that important. The key thing for me is that they found no difference in any patient-oriented outcome despite seeing less ROSC in the single-dose epi group. Now, this is usually where I would probably go off on a long rant about the Heart Association moving their recommendation on Q to 3 to 5 epi to Class 1, their highest level of recommendation. Obviously, I disagree with this, but instead of me ranting, I'm just going to read a section from the discussion in this paper because I couldn't agree with it any more. Quote, although the single-dose epinephrine protocol was associated with similar survival to hospital discharge rates as the multi-epinephrine dose protocol, it was associated with decreased ROSC rates. These results, in context of the existing epinephrine literature, should give clinicians pause when interpreting and applying resuscitation guidelines that prioritize epinephrine for cardiac arrest. The American Heart Association gives epinephrine administration the highest possible recommendation. This Class 1 recommendation indicates that epinephrine, quote, is recommended or should be administered, and that it is, quote, indicated, useful, beneficial, unquote. However, our study and contemporary resuscitation literature do not support this level of recommendation. It is not clear that multiple doses of epinephrine are associated with improved outcomes, especially patient-centered outcomes. Furthermore, achieving ROSC in a neurologically devastated patient or in a patient who does not survive to discharge is expensive, contributes to hospital overcrowding, and is not cost-effective. Therefore, it may be reasonable for EMS medical directors to modify their resuscitation protocols to a single-dose epinephrine protocol and to emphasize interventions such as team-focused CPR, high-quality chest compressions, and defibrillation, which are known to improve patient-centered outcomes. I'm just going to leave that there. Well said, Dr. Ashburn. Well said indeed. Now, the reason that I feel so strongly about this, and I wanted to do an extensive quote from this paper is, yes, it agrees with what I've said, but when I posted something on Twitter announcing the protocol change that we had done in Williamson County that I'm going to do at MedStar of limiting epinephrine dosage in contradiction, if you will, in a way that is different than ACLS, I actually had people on Twitter, smart people, not trolls, smart people, tell me what I was doing was unethical because you have to do what ACLS says, and if you're not doing that, that's research without consent. I strenuously disagree with that. I wanted to add in the quote from Dr. Ashburn on this also. All right, so I want to help put this paper in context of the other literature. And to do that, I briefly want to discuss another paper. So its title is Epinephrine in Out-of-Hospital Cardiac Arrest. Love it when they just get to the point. This paper was published by Dr. Fernando and colleagues just this month, August 2023, in the journal Chest. They performed a network meta-analysis looking at the association between various epinephrine dosing regimens and survival. So for your second nerdy tangent of the pod, because this discussion of generalized estimating equations wasn't enough, I can hear you asking for more. Let's talk about a meta-analysis. So the typical meta-analysis that we're all familiar with finds all of the papers they can that looked at the same comparison. Let's say intubation versus BVM in cardiac arrest. Now, by pooling the results from multiple, presumably well-done studies, they can theoretically analyze greater power to detect small differences because they have a larger sample size. The key for this discussion is they are combining studies that looked at the same comparison. A network meta-analysis, on the other hand, can compare multiple comparisons. For example, they could look at, say, intubation versus BVM or intubation versus supraglottic, and then finally BVM versus supraglottic to come up with one conclusion. Now, in this network meta-analysis, Dr. Fernando looked at studies of epinephrine versus placebo, high-dose epinephrine versus standard-dose epinephrine, and then standard-dose epinephrine plus vasopressin versus standard-dose epinephrine alone. This study, this network meta-analysis, does include the paramedic trial, and that's very important because that's probably the best evidence we have on this. And they conclude, even with paramedic 2 in the mix, that standard dose, high dose, and epinephrine plus vasopressin all did the same thing. They increased ROSC without improving overall survival or neurologically intact survival. In other words, all of these studies are saying the same thing. Epinephrine saves the heart at the expense of the brain. That's great, Jeff, but where does this all leave us? Well, this is my opinion on this. I think there is clearly a benefit from epinephrine. In other words, it helps the heart. The question is how to use it for the benefits we get with it, but without the harms. One thing that might be a clue here is that epinephrine probably doesn't impact all patients equally. In Fernando's meta-analysis, they analyzed outcomes based on the initial rhythm, and they found benefit in survival to discharge in non-shockable rhythms, but not in shockable ones. They suggest that maybe this is because some patients who present in non-shockable rhythms, particularly PEA, may actually be in profound shock instead of true cardiac arrest. And if so, these patients probably do need epinephrine, do need pressors. But think about how we would treat a patient with profound shock, assuming it's not hemorrhagic. Well, we'd start them on vasopressor infusions. Maybe give them a little push-dose epi before starting them on an epi or a norepi drip. Maybe we should be doing the same in non-shockable cardiac arrest. Maybe give a large push dose, say 0.5 milligrams, and then follow that up with an infusion. Now, to be clear about this, I have no idea if that's the right answer or not. It makes sense to me, And I think it is an ethical thing, and I stress that again, I think it is an ethical thing to do given the evidence we now have, including from these two papers, that what we're doing right now isn't doing what we want or what patients want. And this is what I implemented in my prior systems and what I'm going to be implementing here in Fort Worth. We would give 1 milligram of epi as soon as possible to all arrest, and then no more epi in a shockable rhythm, and we would start an infusion for non-shockable rhythms. So I'd love to be able to tell you what the results of that were in my prior systems, but I managed to pick 2020 as the perfect time to implement this change. And as y'all remember, the Earth stopped rotating over the past few years, and everybody's survival dropped. As usual, COVID is the reason we can't have nice things. I don't have any way of teasing out the impact of the epinephrine change from what we saw because of COVID. Now, I will tell you, there is an ongoing trial in Canada right now that is currently enrolling patients. May help here. It's called the EpiDose trial, and it's looking at standard dose epinephrine versus low dose epi in patients with shockable rhythms. They're defining low dose as 2 1 milligram doses, and they're looking to enroll about 3,800 patients, which should give them more power to detect differences than we see in this North Carolina paper. It should be available in about 4 years or so. We'll find out. And my hope is sometime in that time, we will also see something similar in non-shockable rhythms. And then I would love to see something that looks at a lower dose, initial dose, followed by vasopressin. All right, guys, that's what I have for y'all today. I'm interested in your thoughts on this. I really am. Please drop me an email at jeff.jarvis@flightbridgeed.com or on Twitter at Dr. Jeff Jarvis. Now, I'm also on Threads at Dr. Jeff Jarvis if that works better for you. As always, thanks for listening, and thank you for continuing to care for patients day in and day out in a high-stress, difficult position where frequently our patients don't recognize the value we bring. I do. Thank you for what you do. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the Flightbridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.